Okay, I'm going to start letting people in, Chrissy.
Good afternoon.
Good afternoon, all.
Yes, thank you so much for joining
Welcome.
us. We're going to get started pretty shortly. We're going to give people just a minute or two to log on and join us on today's meeting. Hello, good afternoon. Welcome. We're going to get started in just a few minutes, giving people enough time to log on and join us. Okay, we're going to go ahead and get started. And as people log on, we're going to make sure we're allowing people into the meeting. But welcome, happy Monday, and welcome to ABC's Health Equity Alliance meeting for April 2025. Our Health Equity Alliance is one of the most important things that ABC is engaged in from my perspective. Many people don't know. And if you haven't met me, let me do that first. My name is Chrissy Thornton. I'm the president and CEO of Associated Black Charities. Many people don't know why health equity is so important to me, but I actually built my entire nonprofit career in patient advocacy organizations. And so I was with the National Alliance on Mental Illness for almost 8 years, moved to the Leukemia Lymphoma Society. I ran the region, Maryland and Delaware, for the Crohn's and Colitis Foundation. And then I also worked for a rare disease organization, international rare disease organization, before coming to ABC. And so coming to ABC and knowing how in those organizations there were many challenges in engaging communities of color and other marginalized communities. There were many challenges despite those wanting to authentically engage for it to actually manifest. And then also being the parent of a son with a chronic illness here in Baltimore, Maryland, I know what it's like to navigate the healthcare system as a Black person, as a Black family. I know some of the challenges that we faced and continue to face in doing that. And so it is my heart's desire that organizations, practitioners, healthcare institutions really not only commit to the work of engaging equitably and engaging the Black community, but begin to master it. And I believe personally that one way we do that is to create peer networks of those of us who are doing the work so that we have open space to discuss our challenges, to discuss what's working, the best practices, and to hear from people who are doing great things in the realm of health equity. And so today, that's what we have here. Some wonderful guests that you'll meet shortly. But if you are able to, I'm going to ask you to come on camera because this is how we build community and build relationships. Now, if you are not able to, we understand that, or if you're horribly disfigured, there's that too. But we're going to ask you to come on camera so that we can see your beautiful faces today and we can engage in relationship. And I'm going to ask you if you are willing to put your contact information in the chat, who you are. You'll have opportunity throughout the meeting today to talk, but we would love to know what organization or what aspect of healthcare or patient advocacy you represent. If you want to drop in a LinkedIn link or any other information to connect with you, please do that as well. So, welcome. We're going to get started, and I am so very excited because for this week meeting, we have some experts on the line who are doing the hard work of authentically engaging communities, specifically working very well and seamlessly with the Black community. And I'm so excited for you to meet our guests today. I'm actually going to give them the opportunity to introduce themselves and to talk about the great work they're doing. So, we're going to hear first from Patrick and Gail, who are going to tell us a little bit about their work. While we're having this discussion, if you have questions, feel free to put them in the chat. I'll be monitoring the chat, as will our guests. Feel free to come off mute or raise your digital hand. We don't want you to wait if you have a burning question. And then we'll also have some time at the end of our meeting today for just open, unstructured discussion where we can talk about all of our work and hopefully solve some challenges, build relationships, and do all of the things that are going to help us be better professionals. So again, welcome to ABC's Health Equity Alliance meeting. If you are not a member of the Health Equity Alliance and you would like more information on that, please put member in the chat or membership, and Chevelle will reach back out to you so that you can join if you are here as a guest today. And with that, first of all, welcome, Patrick, Daniel. Daniel, that's probably the first time I've called you Daniel, Dr. Mullins, and Gail. I'm going to turn it over to Patrick and Gail to take over our meeting from here. Thank you so much.
Well, thank you so much. It is an honor and privilege to be here today. My name is Patrick G. I currently live in Richmond, Virginia. I'm a healthcare consultant and global patient advocate. I currently live with diabetic kidney disease. On the 21st of this month, I celebrated my 8th kidney transplant anniversary. And thinking back on the challenges that I had with my transplant in the kidney community, we tend to name our new organs. So I named my organ Lazarus, as in the Bible, in the book of John, because when I first got my transplant, I was dealing with delayed graft function. So I still had to end up doing 24 hours of dialysis at bedside every other day. And I endured 4 surgeries, 33 days in the hospital, 6 days of rehab. And on the 47th day, my kidney awoke. And, sometimes when you share your story, it's a constant reminder of the little things that mean so much. So prior to my transplant, I wasn't able to urinate for 2.5 years as an adult. So that first drop of urine was very transformational for my advocacy and for me to just create a faith-based nonprofit called I Advocate, which we merge faith and health literacy to be able to go into underserved, undervalued, and disenfranchised communities of color, just to be able to share information relating to kidney disease, diabetes, heart disease, obesity, and hypertension, which is now being termed cardio-kidney metabolic health. But in my role as that, I was able to come across the Patients Professors Academy in 2023, and I'm very proud to say that I am a graduate of the class of 2023, as well as being a member of the Patients Program Steering Committee. And one of the things that the patient program did for me, I will never forget the first time I wanted to participate in a clinical trial. It was at my dialysis center. It was introducing telehealth. This was in 2013, the same year that I started dialysis. And what was so interesting, I met the qualifications to participate. The problem was when my director of the dialysis center told me, she was like, Patrick, you can't participate in this clinical trial because we can't profit off of your health data. And then she went to say, he who owns the data owns the patient. And because we can't make any money off of it, you can't participate. So that right there kind of threw me into this uproar. And I really started researching clinical research and why people of color weren't allowed to participate in research that was most prevalent for them to be able to manage their health care. So in comes the patients program. And one of the things that the patient program taught me was to go from being invisible to invincible, from going from being in the shadows to now having a seat at the table. It has helped me to find my identity. It has taught me not to just be a seat filler or just a tokenized person that said that, we have a Black person, but to also be a credible messenger, to also help clinical trial teams that don't have private investigators that look like me, to be able to go into communities that they aren't familiar with. One of the things that really used to make me upset was when clinical researchers would tell me, hey, how do we talk to folks that look like you, just like you're doing right now? There's no barrier. Just have that conversation. Learn to treat the person's humanity before you focus on their health affliction. Get to know the individual. And through the patients program, I have been empowered to kind of talk about cultural humility, to talk about why everybody needs to be at the table, and we need to be very respectful of those folks, and to really make a concerted effort to get into communities that are dealing with racism, lack of access to healthcare, to be able to get these folks to understand that clinical research has changed since the 50s and 60s and 70s. And now there are a lot of safeguards for folks from marginalized communities to be able to participate, to protect their data, to protect them overall, and to also help them to be able to have a voice in research. Because one of the things that I really learned from patients was this saying, nothing for us without us. So I'm very grateful for the patients program and everything that it's done for me.
Hi, everyone. I'm Gail Graham. I'm the director of Mount Lebanon Baptist Church HIV/AIDS Outreach Services, and I'm also a patient professor for the University of Maryland Patients Program. In April 22nd, 1997, I was diagnosed as HIV positive. And one of the first things that I wanted to do was learn as much about HIV as possible so nobody else would have to go through what I was going through. Fast forward to my best friend actually joining a church called Mount Lebanon Baptist Church. And she invited me to come a couple of times. And I said, and I went and I really liked the church. And she asked me, well, Gail, when are you going to join? And I said, well, I don't want to bring the stigma of HIV to this church. So she said, well, why don't you talk to our pastor? So the next week, literally, Pastor found time, Dr. Franklin Lance found time to meet with me. And I told him my story. And he said, Gail, this is your ministry. Now, if you know Dr. Lance, he's fine and everything. But when he's, he just meeting me and he's going to say, this is your ministry. I was like, okay, he's not all there. But needless to say, a year later, we actually started the Mount Lebanon Baptist Church HIV Outreach Services. And Dr. Mullins came to our church one day, and he already talked to Pastor, and they had a meeting, and Pastor invited me to come to the meeting. And I said no, because by this time, we had a lot of people coming in and out of the community, which was a 21215 area code, which had a very high rate of HIV. It was a food desert, and we had a high reentry rate in that community. So people were coming in, taking advantage of my community. And I was at a point where, no, I didn't want to do anything else with any more researchers or companies. But Dr. Lance was adamant. So I was like, okay, I'll go to the meeting. So I met with Dr. Mullins and his team, and he told us about the program. And he said, well, Gail, do you think you'd be interested in joining? So I said, no. So after a couple of times, he asked again, and I kept saying no. So then finally he said, well, maybe one of my postdocs can meet with you for lunch. So a week later, the postdoc came out and she met with me, and she gave me a spiel, and I again said no. But then she asked if she could have a table at our World AIDS Day Testing for Turkey event. And that event is where we would give away a whole turkey and food and clothing, anything we could give back to our community with. And we were encouraging people to get HIV tested because it was World AIDS Day. So my thing was I was going to put them in a corner and just watch them, make sure they didn't interfere with anything. But this organization came, and they were not worried about having a table. They were not worried about, putting their product or whatever out there. They wanted to know what they could do. So they went out and bought coffee and donuts for our community. And I completely forgot that they were there. And I turned around and looked, and they were sitting with my community. Again, high rate of HIV. We're not used to people wanting to touch us, but they're actually sitting there holding our hands and listening to what we've seen. And when I saw that, I said, okay, you got me. And what they also did, they stayed in our community. It wasn't just for that one thing. And once they realized that, we wanted to give back because it was a food desert, they gave us a connection to the Maryland Food Bank where we can, give back as much as possible to our community. And so Dr. Mullins, actually, even though I said no so many times, he is my mentor now and my close friend because of him, I was able to find my voice and see the power of my voice. And I was actually on a community advisory board for Johns Hopkins University AIDS clinical trial unit. And I was able to look at protocols before they went out to the community. And I was like, how can I do this? And I have not experienced a research protocol myself, much less a lot of people had a lot of distrust for Johns Hopkins period and the Henrietta Lacks issue. So Hopkins didn't have a trial for me at the time. So Dr. Mullins encouraged me to, talk to my own doctor. And, I wasn't even thinking. So I did. I talked to my doctor and I got into a research trial and I loved it. And I was able to go back into my community and tell them how research has changed from Henrietta Lacks to now. And so I think that makes a difference because we're going back into the community as a Black woman who actually experienced the trial, that another Black woman that they took advantage of, and I could tell them what happened because of that. So that's one of the great reasons that I'm in research and I'm doing the trials, as well as I started off on AZT, and now I'm on medicine that I take once every other month. And it was only due to other participants who were able to do that. So now I'm able to give back to my community also. Thank you.
Thank you so much. Your stories, both of them, so inspiring. And this is what I think moving from mistrust to actually being included in the work really looks like. And so I'm so happy now to pass it off to Dr. Mullins to tell us all about the Patients Program.
Thanks. I'll start by saying that one of the things we do with the Patients Program, which is a community academic partnership, is start with what we call Patients' Voice. Because it helps us to really ground why we come together. And so I want to first thank Patrick and Gail for sharing a little bit of your stories today as you have with us. The Patients Program started with a federal grant back in 2013. And the idea was to build an infrastructure in partnership with patients and other partners who influence patients' decisions about their healthcare and research. And one of the people who was part of the original steering committee was Dr. Lance, whom Gail mentioned, who's the senior pastor at Mount Lebanon Baptist Church. The way that we set this up, University of Maryland, Baltimore, which is the university here in the city, so we're not UMBC out in the county, or College Park down in College Park. We're the health professions campus of the University of Maryland system. We have 7 schools. And so those schools include the School of Pharmacy and other health professions like medicine and nursing and dentistry, social work. But it also includes the School of Law, and it includes the graduate school. And one of the things that we did is we recognized that we had 7 schools, and so we wanted to have at least 8 outside partners, so that when we made decisions, we were making decisions in partnership with community leaders like a Pastor Lance or an Aurelia Laird, but that those partners could outvote us. And I felt that that was a really good governance structure to keep us honest, so that we wouldn't repeat the mistakes of research in the past. Well, fast forward, it's been 12 years. The first 5-year grant ended 7 years ago, and we're still going strong. And a couple of years ago, at one of our staff meetings, I said, we really need to honor people like Gail. Gail wasn't too excited about meeting me, as you heard, because of her experiences with other researchers. Maybe later she'll talk about the nickname that she came up with me for why I stuck it out and why she stuck it out. But I said that these patients have really been teaching us what we need to know. And that's why we've been able to survive, not just beyond the 5 years, but really continue to do really innovative work. Because we now have learned from these patients how to do research differently. And so I came up with the name Patients, the name of our program, it's an acronym, Patients Professors, because they were our professors, our teachers. And the idea was that we had learned so much, and Gail and other patients professors had traveled around the country with me to try to teach this to other organizations, but we were starting to get so many requests that I thought we really need to start this academy. And the academy would be like, a university or any academy, that we would have little readings for people to do before they come. And we'd have our professors, and those were patients professors like Gail, and then some of us who were at the university doing research. And we would co-present in the academy this model that we've used of really bringing together the different voices, whether it's a patient or one of their care partners, informally at home, or maybe one of their community-based providers, or maybe it's somebody who works for an insurance company that decides whether or not the prescription that you get can be filled, or maybe it's a policymaker who works for a city government or a state government or the federal government who really has an influence on health in America. And we've been doing this now for 4 years. And the idea is that you could be a patient, or you could be a caregiver, or you could be, part of some organization that sets policy. You could be a community leader like Pastor Lance. You could be anyone who really interacts with patients, and you could come into the same classroom virtually and learn how to work together to do research differently. And as Patrick's one of our graduates, we graduate about 90 people every year. And then they become patient professors, and they go back to whatever communities they belong to. Many of us belong to a variety of communities. And the idea is to really change the way that we approach helping people to be healthy, by really listening to what are the important questions that patients have, and then serving as a bridge between patients who have real health challenges and researchers who want to help improve the lives of people, but sometimes their research doesn't really do it in a meaningful way. And then together to figure out some solutions to make research more meaningful. And then as we learn, to make sure that we bring back to everybody, not just the people who participated in research, what we've learned, so that we can improve health right here in West Baltimore, but really across the country and increasingly across the globe.
Thank you so much, Dr. Mullins, for talking to us about your program, which is so successful. We've had so many people who have come to ABC either already trained as a patient's professor, as one of your ambassadors, or that we've sent your way. And we really believe in how you all are connecting with the community. I have a couple of questions for you all, and make sure that you all, if you have questions specifically for the team that spoke this morning, that you either raise your hand, come off mute, we'll see you do that, or put them into the chat. But as we talk about, and Gail mentioned a little bit of the historical harm that Black communities, specifically here in Baltimore, have faced. How do we really start to rebuild trust? And what role do patient advocates play in shifting, this narrative of history, which is important, very important, but more to a conversation of equity and our involvement?
First, you have to acknowledge what happened in the past. And you don't go into the community with a savior complex, like you know everything. That was a big thing that was happening. Helicopter research, people was just coming in, taking from our community, which was making the situation worse. They weren't trying to build trust. They were taking advantage. So what's important is first, when you go into a community, you build the trust with that community. You acknowledge what happened before. You try to dispel some of the myths that's happened. It's good if you could go into the community with someone that looks like them, that can explain, on their level about, research and what's happened and the changes within research.
Absolutely. And if anyone else has thoughts that's on the meeting today, remember this is a meeting, so we want to make sure we hear from all of those who have something to contribute. I think building trust.
Chrissy, I was going to jump in and say that,
go ahead.
it's interesting because Gail wrote an article with us probably 8 years ago now. It was a while ago. And we were grappling with this issue. And I think a lot of researchers nowadays bring, some of their patient and community partners as co-authors, but I don't know that they really spend the time to talk through the issue. So we're talking about this, and Gail said, yeah, but the issue is that sometimes when you have a health problem, you really have no choice but to trust somebody. But that doesn't mean that they're going to necessarily be trustworthy. And that really stuck with us. And we wrote this, a lot of people are talking about that now, but back then we all stopped. And that was really something that drove the way we wrote that proposal, which is that oftentimes we're looking to get a patient to change their behavior, rather than thinking about a research institution like my own needing to change what we do and how we do it so that we would be more trustworthy. And so I just wanted to add in there that you're right. I love what Gail said about really talking about what has happened. And I've been corrected sometimes by people who say, and what continues to happen today. It's not all history. But also, where the focus on who needs to change lies.
Absolutely. That's amazing. An amazing point. I think too, as we look at building community, and Gail mentioned it never hurts to have someone who looks like the community to go in with you. I think too, though, I have found in some of the organizations where I worked, where I was that person that looked like the community, we also have to remember that we're not monolithic, and one Black person doesn't speak for all Black people, and one gay person doesn't speak for all gay people. And sometimes this work, there can be a token in place, and we believe that that's enough to reach the community, and that's not the case either. Anyone else have something they want to add to this topic, or how it relates in your own work, your own even personal experience? Okay. There's a question, do patients trust more with each other or with health professionals? Well, I'll
Each
answer
other.
that first, right? Like as a caregiver, and you said each other. I will
Yeah.
say, as someone who was a scared mother with an 11-year-old child who was debilitated in front of my eyes, that I had to trust the healthcare professionals, right? Because I didn't know what was going on with him, and it was a blind trust, right? Like it was a listen, and it turned out well in my case. But I think we deserve to be able to trust both of those things. And so it's, go ahead, Patrick, you want to give a little insight?
Yeah, the reason I say each other is because there are times where folks come right out of medical school and they treat the symptom, but they don't treat the person. So they don't always understand everything that's going on physically, emotionally, mentally, spiritually, socially with that individual. But if you go to a person who is suffering the same affliction, impact, they tend to understand. They tend to listen with empathy and sympathy. They don't try to prescribe anything but hope. And even somebody's presence can be the beginning of healing. And you don't always find that from a physician. And of course, now with a lot of patients asking institutions to consider classes on cultural humility, like I said before, you have to treat the person before you treat the affliction, and you can't do that again with helicopter treatment. We certainly understand physicians only have a certain amount of time to engage with you, but to sit there and to minimize a person based off of the physician's ideology and stuff like that. And I give you an example. So I am at a cardiology appointment, going through an EKG in preparation of getting a transplant. And the form of dialysis that I did for 4 years was peritoneal dialysis. So I'm not sure if anybody is familiar with peritoneal dialysis, but this is where they take and place a catheter in your underbelly. So I had the top part of the catheter taped on my belly. So I had to take my shirt off. And the nurse didn't see me when I took my shirt off. But when she turned around and she looked at me and she saw this plastic tube taped to my stomach, she yelled so loudly that a number of staff came in, including security. And she pointed at me and was like, "What in the hell is that?" And in that moment, being a Black man sitting there and a white nurse doing this, and in my mind, I'm thinking, well, this is a nurse. I'm thinking she's familiar with everything, and they know that I'm a dialysis patient. I just slid off the table, put my shirt back on, and walked out in humiliation and disgust. Now, when I shared it with some peers, they were like, "Oh yeah, Patrick, that happens all the time." Man, imagine me living in DC with a fistula in my arm and being stopped by police thinking that I'm either a crack addict or intravenous drug user because I have an enlarged vein. So until folks see us, until the medical community see us as silent sufferers, because we don't want to be a burden to anybody. For me, it's better for me to go to my advocacy friends. I know that every time they come out of an appointment, they go straight to researching, and I can understand them and their plain language summary versus sitting in a physician's office, especially one that does not know me, and they're talking a whole lot of medical jargon. And I really wish that Google Translate would actually have something in there to break down medical jargon to, like a 4th or 5th grade level so that every patient could certainly understand.
I'm so sorry to hear about and I'm sure you're not alone with some of the encounters that people have had in the healthcare system. Anyone have anything to contribute? Yes, Keyshawn.
Good afternoon, all. My name is Keyshawn Johnson. I'm a board pipeline alumni. I want to first thank you all for sharing your stories. And I want to offer this. I'm going to say a lot about her and she. My wife is Joy Johnson. She's a board certified behavior analyst. She's also the only autistic Black board certified behavior analyst in the world, right? She writes extensively on things like this. She talks a lot about cultural humility. I'll put the website in the thing, so just in case I get anything wrong. But she talks about being different and not less, and how healthcare providers used to typically treat differences, right? And why, as you said, Patrick, cultural humility is something that is key to healthcare, right? Um, a provider with cultural competency, right, as I understand it, is a provider who understands the community that they're dealing with, and understands the nuances of that community provides. Um, for my wife, as a BCBA who treats who supports autistic people, um, her approach to care for her clinic is assent-based care, where it is individualized toward the person. And if the person says, hey, that is something that I'm not comfortable with, then that person has agency over the treatment that's being provided to them. Currently, we are located in the Timonium Towson area. As of June, we will be the only ABA clinic in Baltimore City. We'll be located in the Cross Keys. But please, if you all have anybody who needs this sort of support, please understand that we are here to provide support like that for the community. And if you all need to reach out, we are available for conversations on the subject as well. Thank you all for letting me speak.
I love the opportunity for us to converse about these things. I wish there were more people on the line, and we'll share the recording. There were a lot more that registered who aren't as culturally engaged, possibly, although we are learning from one another as well. What I will say, though, is I personally don't believe in cultural competence, and that's why I try not to use that. I try to use cultural engagement. Cultural humility is my new jam. Thank you for that. I don't believe you can become competent in lived experience where you don't have membership, or where, that you don't have. I do think you can learn and grow and become engaged, but not competent. And I think because people know they can't be competent, they don't even try in some instances. It becomes like a us versus them thing. But one of the things we talked about last time on the meeting, and I'd love to hear from a patients program perspective what you think, we talked about terminology and how it can be triggering, especially in Black communities. Like you talking about trials, the clinical trials, it might be triggering for some of us and some of the stories that have been passed down. Hopkins, as Gail mentioned, that's triggering. Although, I owe my child's life to Hopkins, and so it's a shame that some of the stigma is still there because there's good care. What do we, talking about support groups, we know that a lot of Black men are not going to sign up for a support group. I have a friend who calls her support group the Huddle, and has many Black men come because they, can, I think, relate to that terminology. It seems less threatening and less assaultive to them. What do you guys think about that? Like, what can we do as people who want to bring Black community members to care and advocacy and all of that to make it more, where they can receive it?
Well, patients need to be put at the beginning of research, from the very beginning until the very end of research. And that way, as the language is developed, we can correct them on that, because, we were originally called subjects. Nobody wants to be called a subject. We're participants, we're patients, we're choosing to do this. We're nobody's subjects. And so that was a big thing in the community. Once you heard that, you're not going to get anybody to volunteer for anything, because it brings back the different things that happened to our community in the past. So yes, language matters, but that's why it's important that we are in a place in research where we can make a difference, even as community. Just being a part of it from the very beginning all the way to the end, when we disseminate that information later back to our community, it will make a big difference.
So I'd love to talk. Oh, go ahead. Yeah.
Oh, and if I can piggyback off of something that Gail said, here's what helped me. When I was in orientation for the patients program, they did something that I had never seen in my 62 years on earth. They had a land acknowledgement. I had never seen that. It was so emotional to read that somebody accepted responsibility and acknowledged the wrongdoing. And here is what we are doing to rectify that. If that starts, imagine what would happen, not just with clinical research, but inhumane treatment, if everybody said something as simple as, you know what, my bad. I apologize. I take responsibility. This is what I want to do to move forward. Can we have a conversation around this? Healing is beyond any prescribed medication. And this is just my opinion. Healing actually begins, in my opinion, through acknowledgement that you actually hurt somebody. And when you can authentically say that and have a conversation that's open, free-spirited, but also engaging and learning, it can break down a whole lot of barriers. And what Gail said is right on point, because just, I don't know if this happened Friday or Thursday, but there was something that came out where members of Congress was discussing something that had kind of torn the Black community apart a while ago, and now they're bringing it back to kind of make it more acceptable that African Americans were 3/5 human. So this discussion is still prevalent today.
Yeah,
So,
I just saw something on that today, actually. I was thinking
yeah,
of a t-shirt made that said something about the three. That was in the original Constitution.
right.
That's 3/5 of humanity. Wow. Gwendolyn?
Uh, just joined the conversation a little late, but I think I get the gist of it. My name is Gwendolyn. I'm from Baltimore, and I'm a formerly incarcerated, justice impacted person. The words that I just used are exactly, I think, what we're talking about. If we don't have people who have been impacted, we don't have people who have been the clients, the participants involved in the conversation, then hurtful terminology can continue to be used. In the environment that I'm in now, the formerly incarcerated, justice impacted people who have been formerly called inmates, prisoners, felons, we are striving to get away from those words, just as you all are striving to get away from the words that are used in the trials. It is imperative that people with that lived experience are in those rooms, are in those the beginning, just planning stages, so that our voices can be heard, and that terminology is one of the easiest things to trigger a person from a yay or a nay. So that's about all I had to say. Thank you.
I love what I just heard, and I just want to first thank you for sharing that, and secondly say I spend my life listening to people who, and I tell all of my colleagues how many people are willing to help, right? Like how many people really understand what it's like to face health challenges, and I think we just need to get out of our own way sometimes, right? So I think both what Gwendolyn said and what Gail said about really asking someone, how would you phrase this? Or if you were talking to somebody from your community, how would you describe this so that we learn that language? But then, Chrissy, I want to go back to what you said about people not being monolithic, because I also have had some people who are from a community tell me this is the word to use, and then I use it in the community, and then somebody in the community says, I don't like that word anymore, right? And so what I've learned is it's kind of like what some people do with gender, like, how would you like for me to refer to you, right? Like, so sometimes it's as simple as that. We're not going to come up with like one universal way of doing something, but having the respect and taking the time to say, if I'm going to have a conversation with you about this, like, what language would you like me to use? And then the final thing I've learned is for somebody like myself, because I make a lot of mistakes, is almost to apologize up front. And so, especially when I first meet people, I sometimes say, I just want to say in advance that I'm coming into your community, and it's really a privilege to be able to do that. But since I'm not from your community, I may say something offensive, and I want you to know, like, one, I apologize up front, and two, could you pull me aside and correct me so that I don't make that mistake again? And it's amazing how many people will do that afterwards and say, look, it was really clear what you were trying to say, but you shouldn't use that word, or you shouldn't use that phrase because it can be, and I find that if people believe that you're trying to help, it is okay to make mistakes, and people will help you to recover from those mistakes. And so I think that's the other thing, is sometimes reminding, researchers as well as community members that this is hard stuff, and sometimes we are going to get offended, but if we really are committed to the cause of improving health, we can get past some of the original barriers if we're like-minded and really wanted to solve big problems.
And it's a constant correction that you'll be making. You'll be constantly correcting people all through your advocacy journey. One thing, like my favorite nickname for Dr. Mullins is a pit bull, because he never gave up on me. And he was always, then he stuck by me. And that's why I said he'll never get rid of me now. But when it comes to correcting people as they, like HIV infected, that was the worst thing you could call somebody. Then we came up with HIV positive. But I recently went on a conference for women in research and had scientists still saying HIV infected. So, and I had to say, no, that's not the correct terminology. You have to keep reminding them. If you have that if you keep thinking that way, you're not going to get people to respond the way you want them to respond. And it's you're going backwards instead of going forwards. So it'll be a constant thing, but never give up. Always be that pit bull for your advocacy.
And I think some of the miseducation and ignorance happens at high levels. I remember being at conferences and hearing people from the FDA say things like, Black people don't have childcare or transportation, and naming all of the barriers that they believe Black people have, instead of actually asking the communities and having an understanding of, even as we talk about the social determinants of health, there are people who are not living in poverty that still have barriers to healthcare. But a lot of times when we frame it, it becomes like an economic situation that is equated to Blackness. So all Black communities are not, underprivileged. Most of them are underrepresented, but those two words don't mean the same thing. So there are some serious, I think, things at stake if Black people are not involved in patient studies and clinical trials. So our mistrust can lead to, number one, when they get to the other end of the trial, there's this framing that there were no people of color that chose to be involved, which is not ever true. But then also there are drugs that are developed. There are treatments that are developed that don't serve us physiologically. And and so when we're left out of the study or the trial, then a lot of times we're left out of the medical solutions as well. Anyone else have anything to share? We're kind of having more of an open dialogue. I can give some prompting questions, but we'd love to hear about your work, how you're approaching equity, some of the challenges, some of the best practices, and things you would like to share or ask questions.
Chrissy, I just want to jump in and really underscore something you said. You mentioned the context of like hearing something at an FDA meeting, but whether it's FDA or others, there's this bias that people think Black people don't want to participate in research, hard stop, right? And so we've spent a lot of time really researching that and correcting, that's a myth in and of itself, right? Research is always voluntary, but to label an entire group of people, because there are situations in the past that make people ask the right questions before they decide to participate. But I think sometimes even that is just correcting people when they make a blanket statement about who is and is not interested in research. I think that's really important and something that we remain committed to, is not just doing research in partnership, but also when people make a statement that's not true, correcting them.
And that's important. I'm going to go to Nashima, but that is important because when you say that and you say it over and over again, then Black communities don't see themselves as participants either. And so you're manifesting that by telling us that we don't participate, there's no place for us in this, and then we follow suit, right? And so that is, I would say, by design. That might be a little bit too militant to think that that's the case, but I would say that there's a lot of by design in that. Nashima? Uh-oh, we can't hear you. Nope. All right, I'm gonna go to Gail and then I'm come back to you while you work on your microphone. Gail?
And one of the other things I was going to say too, when it comes to participating in research trial, the research trial has to be accommodating to the people they need to have a part of it. They need women to participate in research trials, but yet the amount of time that they need a woman to be there is not feasible because they manage the household sometimes. They have to pick up the kids, they work, but yet you want them to come 3 or 4 days out the week. You want 2 forms of birth control for them to be on the trials. And then you need to make sure that the whatever trial you're doing is actually announced to the community. We don't know what you have for trials if you don't come into our community to tell us, these trials are available. Do you think you'll be interested? Or better yet, if our community has a high rate of certain diseases, to come in with research trials that address that is beneficial to us. So, we'll listen more and then we'll try to see how we can work that out. But if it's not being presented to us, then how do you expect us to participate in it?
Absolutely. Nashima, you want to try again?
Can you hear me?
Yes, we can hear you.
Okay, perfect. Hello, everyone. Happy to be here. This is my first meeting. I am the new Health Equity Program Manager at Planned Parenthood, Maryland. So happy to be here and meet you all. I wanted to add to the conversation by saying advocacy is like so important in this work. I come from a background of like clinical medicine. I moved to the administrative side, and as a Black woman, a young Black woman at that, I've experienced my own traumatic experience giving birth when I had my daughter back in 2018. I had a high risk result for my daughter being born with Down syndrome. I wasn't told by my OB, and she was born with Down syndrome. So I didn't really have the opportunity to like advocate for myself to say yay or nay. The choice was pretty much made for me, but even like being in the space and now raising her, she's 6 now and thriving. But even when I go to like healthcare providers, just when they look at me, I can tell that I'm already being, I guess, judged or predisposed to certain opinions, which is unfortunate because I feel like it takes away the opportunity to really give her like the best chance, even when it comes in like to like educational settings. But advocacy is so important. I've also worked with Black women living with HIV. And even in that space, when we're thinking about like simple things like long-acting injectables, like Miss Gail, I think that's your name, just mentioned, like when we talk about the research, it's like, yes, this research may work. This medicine may work, but it's not really explained in a way where people can receive it and understand it. So a lot of people are just like, no, you're not giving me another shot. I don't want just another shot. So the information is not digestible for every community when we're talking about like health education and health literacy. So yeah, that's all I have to add. Thank you.
No, thank you for that. Bernard?
Yeah, hats off to Dr. Mullins and Gail and Dr. G. The patient program was just fabulous. I'll go on record and just be very transparent. I watched my wife go through 7 years of trying to be diagnosed with the rare autoimmune disease that she has, to the point where some of the doctors were telling her, that she was crazy, that she was just seeking, medicine, things like that. And it was really unfortunate. Some said she really needed to see a psychiatrist. No, it was almost like no one believed her story until she was able to find a teaching hospital and a teaching doctor who was willing to take on her diagnosis after, like I said, 7 years of going through it. And so the studies were really not available because the rare autoimmune disease that she has is 0.5% Black women who actually have this autoimmune disease. So, so it's organizations like the Patients Program that really give a voice. But, and my wife being a graduate, I can't stop her now talking about just the Patient Program, but also just, her willingness to want to go on record and meet with other people and go into other communities to really talk about what she had to go through. So you really have to advocate for yourself. You can't let others dismiss you, like some of the things that Dr. G lifted up. But you really have to be that strong advocate and use your voice to be able to get things for your own health. So I just wanted to lend that to the conversation as well.
Thank you so much for that. So in the chat, Tiffany mentioned that a lot of her work as a community health worker is about building rapport and resource navigation. So one of the questions I wanted to pose for those on the meeting is, we talk about what's needed is authentic engagement in Black community, but what does that look like? So, we can say healthcare institutions should be engaging authentically, but to you, and we may have differing perceptions of that. What does authentic engagement for Black people based on, healthcare institutions, advocacy, or what does it look like? What does it feel like?
I'll start. I'll say by giving back to that community that they're involved with. That's one of the things I loved about the patients program, because it was never about, what their issues they wanted to push forward. They stayed with our community and was a part of our communities during times which were the hardest, which was through COVID and through the Freddie Gray violence.
Mm-hmm.
When that issue hit, the patients program was the first organization that came to our community and was like, what can we do to help? That makes a big difference in our community, because once a community sees you and they begin to trust you and you build that trustworthiness, again, that's important. Then we see that you actually care about us, but you'll also, you don't continue to give back and not expecting anything. Then you build in that rapport with your community so that you can have that friendship. You can develop bi-directional learning, and you can actually assist the community with things that they need.
Great points. Anyone else have thoughts about what authentic engagement looks like in the Black community?
Yeah, sure.
No.
Yeah, everyone.
Go ahead.
So real quickly, authentic communication looks like, sometimes I feel like when folks set up tables in community and ask for surveying, ask for questioning, it's more of a take thing, right? You're asking them for their information, you're gleaning off what you need to help support in your studies and to, I guess, further your research and your projecting. But what does it look like if, as someone mentioned earlier, we're in a community when there is not a need for research? So if someone is there just handing out food in the school or just supporting and being a mentor in the different spaces. So just having your face being more familiar, gaining that trust, learning how it is to live and be in that community. And I think that also goes back to seeing the humanity in other people and seeing them as more than just a ways to an end, right?
Thank you. Patrick?
Well, I agree with everything that's been said. I was going to talk about that humanity piece. Authentic engagement is when somebody takes an interest in you beyond your affliction. Just sitting there, getting to know the person before you know the ailment, and the community that they come from. And it becomes an investment. I know for me, my care team, even though I know they are concerned about, all the things that are going on with me physically, but they invest in my advocacy. They are very strong in saying, hey, Patrick, I know you're into clinical research. Have you ever thought about this research or that? Or you want to talk about a particular prescription or medication, or what do you think about this? So it becomes extremely engaging. And in that moment of used to feeling invisible, now I feel visible. I feel a part of the conversation versus somebody who is often dictating to me what I need versus giving me the information so that I can make a viable choice in the management of my diseases.
So if I had to summarize, it sounds like empowerment.
Yes.
Mm-hmm.
I would
So,
also like to
go
add,
ahead, Chanel.
Hi. So I would kind of like to echo what Kieta said. I also think it's important to be within the community, but to also like bring the community with you. So like we have a ton of youth programs and things like that, like creating those programs where youth are learning about healthcare and clinical trials and things earlier, where they can begin to build careers in those pathways. So now we're not just having to train people to be culturally competent, we're actually using people from those communities as well to engage in these type of topics. I think is super important because those people already have membership and will be great advocates for these type of healthcare and clinical trial settings as well.
That's a big point, right? Representation matters. And while we want to seek healthcare and treatment and support from the best qualified people, no matter what color they are, or how they show up, or what they look like, having representation always creates a different level of comfort. So we have Tiffany and Nashima.
I just wanted to veggie bag. That was something we learned yesterday instead of piggyback. Veggie bag. I think it's cute. But just to echo what you talked about earlier in reference to the empowerment, I like to say co-powerment because a lot of times in these situations, we are, I'm giving you power and you're also giving me a sense of power, whether it be knowledge, education on a topic that I did not know about, or just the relationship. So I just wanted to say co-powerment because that just resonates with me very much. So I just wanted to
Okay.
share that. Thank you.
Nashima, you had something?
Yeah, I like the empowerment as well, but I'd also like to say, like, when we're thinking about this work, I think we can kind of like talk about the problem in different settings or different community environments all day, because obviously there's a plethora of issues that we could talk about, but like, are we bringing real solutions to the table that's going to impact the change? I feel like these days we're very caught up with like, focus groups or like any type of like community roundtable kind of talk about the problems, like town halls and things of that nature. Um, but I think it's time to move to the solution, the solution part of the conversation, which I don't think we're having enough conversation about currently.
I agree. So let's shift to that. Let's talk about how do we begin to see the needle move, right? Like, because we do a lot of ideating, we do a lot of strategizing. How does the needle move, and how do we influence the needle moving in the right direction for Black communities to not only be regarded as humans for their voice, their pain, their trauma, and all those things to be acknowledged, for the historical wrong, I can't say the word corrected. I don't think it can be corrected, but for the historical wrong to be acknowledged and utilized to inform current, support mechanisms. How do we begin? Where do we start? Because as Nashima, we'll have this conversation for the rest of our lives. And right now, Baltimore specifically is one of the highest rates of Alzheimer's. um, you know, we stopped talking about that mesothelioma over there from Bethlehem Steel and how that is actually tracking generationally in people's DNA. I just heard that. Like they're the grandchildren of people who worked at Bethlehem Steel who will have genetic markers to be more predisposed to the carcinogens and stuff like that because their grandparents worked at Bethlehem Steel. How do we have people who are still driving past the emergency room at Johns Hopkins and dying in the car rather than stop there? Like, so how do we begin to have real change? Any thoughts?
I was going to bring up a shout out to Pastor Lance, who's the current chair of our steering committee, and he was the one where we did our last strategic. So we're in our third strategic plan now, and he before he got the calling was an executive in a Fortune 500 company. So he tends to bring back some basic business principles when they're appropriate. And he said to me, okay, but what are our key performance indicators? And the idea of having key performance indicators for having, community impact or an actual impact on advancing health equity. And it was really cool. So we got together 4 or 5 people who have developed key performance indicators, either for like a local community organization all the way up to a federal agency. And we asked them to help us think through how we could do that. So I do think that this idea of not just having anecdotes, but really being deliberate in what would it look like to track and be transparent about, are you actually having impact at the end of the day? So I encourage people to treat it in that sense, the way you would treat a strategic plan for your organization is if it's real, if you have a real goal of making an impact, then you should be able to measure it and show that you're making progress.
So Amber, I had to go off camera because a spider attacked me. I talked about this in the beginning of the meeting. I'm outside, so there's a whole thing behind that. But Amber put into the chat a little bit of, I think, structure, framework, right? Identify the needs, create a strategy, track results. But top needs, which I think is the integral part of what she wrote there. What are the top needs? Because if the top need is building trust, let's just say, then this is a conversation we've been having for decades. How do we ever get past that barrier to move on to creating this strategy? Any thoughts? Dim says, empower Black community first. So the spread of voice of us. Okay. Any other thoughts?
But this one I would jump in and say that, I have a lot of colleagues at my university, and they think they're doing this because they convince themselves that they've made a difference. But I'm not sure that the participants of their studies would agree with them. That's why I think it's important to measure.
Okay. Any other thoughts? Anybody doing anything that you think is working particularly well?
Well, personally, I like the fact that as a patient, I'm now sitting on advisory boards in areas which can make a difference. I sit in an advisory board which look over protocols to see if it's beneficial for my community or not, and where we can make changes and speak to the researchers directly before it hits our community. I sit on an advisory board for the Institute for Medicaid Innovation, where I can actually speak on we look at the changes in Medicaid and the healthcare system and everything, but the voice of someone with lived experience who's been on Medicaid makes a big difference, and they listen to you. And I'm not only a board member, but I'm a governing board member, a part of that. And I'm also on an advisory board with the patients program. And I'm also a part of being from a patient to a patient professor who now is able to teach people about what it's like to engage the community, as well as being on the admission board too, where I get to review admissions packets before they come in. It makes a big difference, because knowing that a voice of a patient, somebody you think your voice is not that strong, to being on important advisory boards makes a big difference. And again, you can't speak for everybody in your situation, but your voice does matter and your experience does matter.
Absolutely. Keyshawn?
So I'm gonna take my spectrum support hat off here right quick. And I'm gonna say this, as a transplant to Baltimore City, I think it's imperative that the hospitals that are here use the historical data that's available. I've been asked to be on 3 different patient experience committees from hospitals in the area, specifically because kind of my my specific religiosity, but also because I'm not from Baltimore. When I speak, people like, oh, I want to listen to what he got to say. He's not from here, right? But when they speak to people who are from Baltimore, it's been my experience that they look at it more as complaining and not like difference making, right? I would like for the hospitals in the area to look at the value of the people that are here, that grandparents went to Sinai and had issues and cousins and whatnot. And I would like for the hospitals to see those people as true human beings who do have the historical connectivity, right? That could be valuable in creating healthcare for the future.
Absolutely. We're going to start to wind down. I have recorded this so we can share it out, so you all can watch it back, share it with others in your work, so that we can continue to have this conversation be in the forefront. But I have 2 questions I want to leave with. The first one is just for anyone who would like to contribute. And we talked about the need for advocates in the Black community, amplifying patient voices. But what advice would we give to people in Black community who are just starting to find their voice and their comfort in navigating doctors, hospitals, research spaces. Because before we can become advocates, a lot of times we have to be able to navigate our own lived experience and issues. So, what advice would we give patients who are just in the throes of navigating, so that we can empower them at some point to become advocates?
That if you're not comfortable at your doctor, that if you feel like you cannot explain what's going on, you feel like they're not listening, you have the power to get another doctor.
Mm-hmm.
You don't have to stay there. No matter what insurance you have, you don't have to stay there. You just move on and find somebody until you're comfortable with them.
Mm-hmm.
So don't give up. Don't sit up there and go back into your shell because they're not listening to you. You speak up. And if it's not comfortable for you, then you go get a patient advocate to speak for you. There's other ways you can do that. You do not have to take just anything in your own healthcare.
Hi everyone, I'm Lauren. I would like to add to that because I'm actually navigating a situation like that with my father, and just not really knowing exactly what to do, who are my allies in the situation. And I think that he is also navigating that while also dealing with his situation, which is, super tough for him, which has created some challenges for his mobility. And my father, if you know him, he's a super hyper independent person. And so just having to deal with the psychological impacts as well as the physical, and then just also maybe the fear of like the unknown of what's to come for the future. And then also just as someone that is now stepping into the role of caretaker, I think that it's, sometimes it's like, all right, well, do I just go on Google University and do my own research and then start scaring myself? Or do I try to speak to other people that might have had this experience, or just tapping into my network of healthcare professionals? Because when you're in that situation, sometimes you don't know what questions to ask. And sometimes you feel, I've felt personally like really overwhelmed about all of it all, just because I'm like, all right, I'm trying to be there, and then you're juggling your own stuff. But then at the same time, it's like, all right, I'm asking these questions. And what I'm noticing is that in the moment, sometimes they don't have the answers, which is okay, but then there is no follow through. And so the same thing when the patient is leaving, they may ask for surveys or whatever, but it's like, what is being done with that information? Like, is the information being assessed, or is it just, I'm submitting this survey because it's a formality, right? And so I think that we need to um, advocate that things are really done, and just really advocate that maybe there are patient advocates while a patient is directly in care at a hospital, and not just necessarily like a case manager, but maybe someone that has maybe been through that experience or whatever. Those are just some of my thoughts around that.
Thank you so much for sharing that. You're absolutely right. And when you're in the throes of it, it's the hardest time to remember sometimes to advocate for yourself, because you're navigating fear and you're navigating the unknown, as you mentioned. My oldest child was sent home from an emergency room, and I was told that, there was nothing really wrong with him. And had I not followed my instinct as his mother and my gut, that he probably would have died, being back home before I got him into competent care. And I will say, because Keyshawn, you mentioned this in the chat, and we didn't go into this today, and maybe it's a topic for another day. But my youngest child has dealt with another issue for about 2.5 years and without resolution. And I felt after the fourth doctor that something wasn't right. And so I put a picture of, he was dealing with a skin condition. I put a picture of it and some information into AI, and AI diagnosed him. And I was able to go to a fifth doctor and said, this is, I believe, his diagnosis. And it turned out it was. And so also, like, when we're starting to have tools that can help us to not only advocate for ourselves, but like, we know our bodies and our situations more than anyone else. And so we also have to empower patients, I think, to follow their gut and use the things at their disposal, right? Because sometimes we can walk in a medical office and we're just a billable hour and that's, not no one's No one's giving us the time. So as we wrap up, because I want to give everyone a chance to talk or participate, and you can, if you choose, you can come off mute and share, or you can put it in the chat. But this is a question I'd like us to resonate on as we leave today, because we have to believe this can get better. If we didn't believe this could get better, there'd be no Associated Black Charities or no patients program. And we have to believe that there's a world where equity reigns in healthcare. And so my question to close out today, and we'll start with everybody and leave off with our three guests, is what gives you hope about the future of equity in healthcare? So it's just something to think about. Kieta? Yes.
Yeah, sure. I'll go next. Similar to what we just spoke about, we are doing this right now. We are talking about what's happening. I think a lot of times, especially when my oldest will be 22 in September, and at that time, in 2003, I had no idea how to mother, how to do any of that stuff. But now I feel like women are more open and more open about doula work, about midwifery, about just sharing that everything isn't perfect, and everything doesn't look the same. Um, and similar to Lauren, I've had a situation where my mother, who since passed, but during that time where I was caretaking her for her being the only child, I joined something called a Benti Circle. And the Benti Circle is we have a WhatsApp group that has hundreds of Black women in there. And I had a question like, she has a rash, I don't know what to do. And then within 10 minutes, everyone was telling me what to buy, what to do, what to tell a hospice nurse, like all the things. So it truly gives me hope that those type of spaces, those type of safe spaces, we're going to exist and then also multiply, so that we don't have all these questions and we're not holding it into for ourselves, and we're all supporting each other because we're all going through the same things, honestly.
So I love that. Safe spaces, building community. Building community. Bernard, you had your hand up. You want to go next?
Yeah, Chrissy, I'll just say again, don't be afraid to connect with those support groups once you do get your diagnosis, because I have seen how valuable those support groups are. You can go back to that support group, and just like Yetta said, hey, I'm having this, I'm having that. There may be others who have experienced some of the things that you're experiencing now at an earlier time. So those support groups are very valuable. But I do believe that there is hope for equity in healthcare, just personally, because what I've seen my wife go through. So I definitely believe that there's hope. And just highlighting again, an organization like the Patients Program is actually one of those organizations that provide that hope.
Thank you. Anyone else want to share before we allow our guests to answer that final question? Anything that gives you hope about the future of equity? Amber?
I think the healthcare landscape is starting to look more diverse in terms of providers. And so I think having lived experience in different communities can allow for more understanding of those patients as well.
Absolutely. Thank you. Kamari?
Honestly, I would say being on this call and just hearing from everyone's experiences and learning from professionals gives me hope.
Thank you for that. Anyone else? Okay. I'm going to turn it over to Patrick and to Gail. Is Gail? And to Dr. Mullins to tell us a little bit about what gives them hope about the future of health equity.
For me, it's being in spaces like this where you have the freedom to be transparent and vulnerable in safe spaces, and to understand that advocacy isn't for the faint of heart. Advocacy is where you can find your superpower. And, all superheroes don't wear capes. And that's one of the things that we really need to keep in mind. So when I think about every time there is a patient professor academy class, and looking at the folks that are on there from different backgrounds and different localities, sharing their experiences and being very transparent and emotional about it. And then they go out into the community and they fight against injustice. That's my hope for that, the future of health equity. We're in very good hands. It may be a slow process, but justice is going to prevail.
Mm-hmm. Gail or Dr. Mullins to close out?
I mean, I would say that what gives me hope are Gail and Patrick and the hundreds, sometimes thousands of other people. I would imagine, Christy, you go through sometimes. I don't think there's ever been a time when I needed help when there wasn't somebody there who was willing to help. And so I kind of feel like if that could generalize, if everybody who's trying to do something here could just ask a friend who could help them. I really think that these big problems actually aren't so big when you've got a group of people who, agree to come together and try to solve it. So I guess it's the past successes that give me hope for the future.
Mm-hmm. Gail, any closing remarks?
Thank you. My apologies. I just think it's very important for us as people to be a part of research so that we can make a difference and that we can learn from research ourselves. Because if we don't have that information, how can we go to our community and really expect them to be a part of research?
Absolutely. So I just like to thank all of you for spending this midday time with us today. These are, where solutions begin with conversation. I always say that imperfect conversations are better than silence. My hope for the future of health equity is that we have more people that join conversations like this that sometimes could be uncomfortable, sometimes can be new environments for them to have this discussion, but where they would value the voices of patients, grassroots organizations, corporate organizations, healthcare providers, because I think the solutions will be found when we all convene together and begin to navigate the problems together. So thank you for joining this session of ABC's Health Equity Alliance meeting. We'll meet again in another couple of months, and hopefully you'll stay connected to this work as well as to Associated Black Charities. Chevelle will be emailing out the recording and some other information for those of you who would like to stay connected so that we can make sure that you're with us again next time. But thank you so much for joining today and have a wonderful rest of your Monday.
Thanks for the invitation, Chrissy.
Of course. Thank you all so
Bye-bye.
much.